So, good morning, everybody. So, today I was asked to give you my perspective on trans PRK versus LASIK versus SMILE. So, my perspective is SMILE is the best. That's it, the end. Of course, yes, I might have some personal bias, and that's it. Thank you for attending my talk. Can we move on to the next slide, ma'am? Right. So, unfortunately, I can't just end it here. So, I have to give you some reasoning and some scientific conclusions as to why I believe this is the case. So trans PRK, I know this is now gaining a lot of attention and it's being marketed as a bladeless, touchless procedure, no flap, biomechanical advantage, and a latest laser. But is this actually true? Is trans PRK something that's actually an improvement upon PRK? So that's a question we have to now ask ourselves. So PRK, as we know, is a first generation excimer laser based treatment. As we know, the range of treatment can be from +4 to -8, and astigmatism even up to 4 diopters. We still use it sometimes as a good option for thin corneas or suspect corneas and for low myopia. Yes, it is a flapless procedure, and also sometimes we can occasionally use it for post smile or post LASIK enhancements also. The disadvantages being that the recovery time is long. The other issue being for high ablations, you can have haze, you can induce aberrations, and it can also give you a lot of post-op irritation and pain. The traditional way of doing a PRK was by using 20% alcohol. You debride the epithelium, dry the stromal bed, and go ahead with your excimer laser-based application. And now to counteract the effect of haze in the post-op period, we can also use mitomycin C. Usually the mitomycin C is applied for 1 minute, and sometimes you can use it even longer in case you have higher ablations. So now we've been introduced to something known as trans PRK. So the essential difference between regular PRK and trans PRK is that the excimer laser itself is used to remove the epithelium. Here, what the claim is, it removes it more evenly, it does it in a more even fashion, and the recovery is faster because the epithelium grows back in a more even way, and there is less pain post-operatively. But if you actually look at this scientifically, this was a publication by Professor Dan Reinstein from London Vision Clinic. Outcomes wise, both trans PRK and PRK were 75% the same. There was no difference here. Haze was the same in 67% of cases, and ironically, pain was more in trans PRK. So, which means when you use the excimer laser to ablate the epithelium, you're actually inducing more inflammatory markers that cause more post-operative pain. But yes, the recovery was much faster in trans PRK. But is recovery and pain actually the most important thing? We have to look at outcomes. Ultimately, the refractive outcomes post-op is what is important. And here is the issue that we have with trans PRK. So this is just photos from our MS39 topographer that we've taken over the course of the last 2 weeks of patients who are coming for refractive surgery. As you can see, there is a lot of variability in the epithelium. Not everybody has an even 50 micron epithelium of the cornea. As you can see, there are different bands of epithelial shapes on the cornea for every patient. So let's look at the first picture here. As you can see, it looks like there's a band of thickened epithelium around the 0-180 degree axis. So imagine you go ahead and do a trans PRK here and you put a 50 micron ablation for the epithelium, whereas there is this thickening of epithelium of almost 60 microns in the center. This will cause uneven removal of the epithelium and you'll have undercorrection and you still have a myopic cylinder left behind. Look at the next picture. In the next picture, as you can see, the epithelium is actually thin in the center and is thickened in the periphery. And in this case, if you go ahead and do a 50 micron epithelium removal with the trans PRK, you're going to have a hyperopic shift. Similarly, down and you see the third picture, there's a very thick epithelium all over the central 8 millimeter zone of the cornea. This patient will be undercorrected if you just go ahead and do a trans PRK without measuring the epithelium preoperatively. Same thing on the last picture also, there's a central island which is thickened. This will give rise to irregular astigmatism because of irregular epithelial removal between the center and the periphery. So if we look at the data which was published by Professor Dan as well, he really coined a term known as epithelial power, which is corneal power minus stromal power. 88% of patients have epithelial power within half a diopter. For those 12% of patients in which the epithelium power is more than half a diopter, you're going to have a refractive miss. So is 12% an acceptable amount of patients in which you can have a refractive miss of more than half a diopter. So that is a question we have to really ask ourselves when we are starting to consider doing trans PRK as opposed to doing routine PRK. So the take home point is trans PRK really better? Think about it. You might have a 12% miss if you're not actually measuring the epithelium preoperatively and taking it into account. PRK is still a good option for primary corrections in thin corneas and low myopia. The risk of haze, yes, is there, but you can counteract it with the use of mitomycin C. Okay, now let's move on to our favorite procedure. So LASIK, all of us are very familiar with. Of course, we know how it works. It involves the creation of a flap with either a microkeratome or a femtosecond laser, followed by your excimer laser application. So the range of treatment is very similar. It's about from +4 to you can go up to -10 diopters of sphere and up to 4 to 5 diopters of cylinder. The most widely recognized procedure, a very high success rate, recovery is very good, and there's no pain. But now let's look at the physics of the excimer laser first. This applies to PRK also. So when you're using the excimer laser, as you know, it has to be delivered from a certain distance from the eye, depending from machine to machine. But yes, this distance is there. It's delivered via mirrors and there is a lag time. So when you start the ablation starts at the center because the cornea is prolate. The center is treated quite well. But as you start to move towards the periphery is not treated as evenly as the center. So which means the center is flattened more than the periphery. This can lead to something known as the cosine effect. And this leads to something known as spherical aberration. So because the center is treated more and the periphery is treated less, what you end up having is a smaller effective optical zone. That means there is no even flattening everywhere. And this compounds when you have higher refractive errors because there's more ablation, more spots in the periphery, lesser treatment in the periphery, smaller effective optical zone, and large transition zone. So this is the reason why when you treat higher powers, these patients have more aberrations and poor quality of vision. This is sometimes counteracted by the newer lasers of the excimer, in which they say you can use wavefront guided or wavefront optimized lasers to counteract this effect. So these lasers, what they do to counteract the cosine effect, most spots are fired in the periphery so that there is a little better even flattening. The other thing is we've all heard about Contura and Topo guided and whatnot. All of these lasers claim that yes, you can treat your higher order aberrations as well. You can treat coma, you can treat trefoil, you can treat spherical aberration. But let us understand why these aberrations occur in the first place. So spherical aberrations occur if, like I said, the center and the periphery of a refracting object is not even. So that essentially occurs when you do a traditional LASIK where the center is treated more than the periphery. But other aberrations like coma, trefoil and quatrefoil, etc., you don't really see them in normal corneas. So your regular cookie cutter patient who comes to your clinic asking for refractive surgery, the eye is not being touched by any other laser beforehand, you're not going to see such aberrations. So 90% of the time when you see your patient, they would not need a customized treatment at all. So unless you're a specialty center who is treating keratoconus and trying to smoothen out the cone and give the patient better quality of vision, this is not going to be necessary for you. So here is the reason why I prefer SMILE for most of my cases. So as you know, this is a purely femtosecond laser based treatment. It uses the laser to create a lenticule of appropriate shape, and you extract this using a 2 to 3 millimeter incision. The range right now is restricted to myopia alone from 0.5 diopters to -10 diopters, and cylinder can go up to -5 as well. Recovery is quick and there's no pain. The only caveat here is that it has a bit of a steeper learning curve in comparison to LASIK. So we know all of the regular stuff regarding SMILE with its biomechanical advantage, lesser dry eye and whatnot. But usually what is not talked about is that SMILE has a flat applanation. So when you applanate the cornea, when you're docking, the cornea is absolutely flat. So which means when you do the treatment, there is an even treatment zone right from the center to the periphery. So there is no cosine effect, there is no spherical aberration. You are controlling the amount of higher order aberrations that you are inducing during this treatment. And like I said, when you are docking with the SMILE, you are docking on the patient's visual axis. That's because you ask the patient to look at a fixation light, and as this fixation light is being looked at by the patient, the cone comes and just lightly applanates the cornea. So you know you are treating exactly on the visual axis. As opposed to when you're doing a LASIK, the laser is treated on the patient's pupil, not on the visual axis. So the LASIK is what is inducing higher order aberrations. Whereas in SMILE, because you are docking on the patient's visual axis, this does not occur. Here is an example of the SMILE docking taking place here. As you can see, the patient is fixating on the green light, which means we're going towards the visual axis. And once we applanate about 70 to 80% of the way, we can then activate suction, and you know that you have a perfect treatment centration here. The other thing is, a lot of people say, okay, but SMILE does not treat cylinders well. Is that actually true? So this is another issue I have. So let's say you're doing a LASIK treatment and you're treating a high cylinder. And as I said earlier, you have to deliver the LASIK from the excimer laser at a certain distance from the patient's cornea. While you're doing this, are we absolutely certain that the patient's eye is not moving at all? And are you sure that the pupil tracker can actually track this in real time and compensate for cyclotorsion? You can't. Whereas when you're doing a SMILE, the patient's eye is fixed. So once you dock to the PI and you activate suction, there's no more movement whatsoever. So you're comparing a dynamic system of cyclotorsion on the LASIK platforms, which can't really compensate for microsaccades of the patient's eye, in comparison to a static system of cyclotorsion in SMILE, where the patient's eye is fixed. So that argument really does not hold well here. So in vast majority of cases also, when you see the amount of cyclotorsion that occurs is less than 5 degrees. And very few patients have more than 10 degrees of cyclotorsion. So again, this whole argument about not treating high cylinders well does not really hold true at all. That being said, the newer platforms of the SMILE and the VisuMax also can address cyclotorsion. So once we've done the docking and you've made the marks on the cornea, you can manually adjust the visual axis to align with those marks on the cornea. So you're sure that any amount of cyclotorsion that could have occurred is corrected in real time while the eye is completely static and not moving. So which means you can correct high cylinders very well with SMILE. So dry eye, as I've said earlier, yes, we all of us know this because the incision is much smaller in SMILE. The subepithelial nerve plexus are much more preserved in SMILE in comparison to LASIK. There is a biomechanical advantage because there is no flap. The amount of remodeling that occurs post-operatively is much lesser. I will not say that you will not have ectasia because I've had patients post-SMILE who come with ectasia also. So that's something that can't be proven. But yes, when you do a LASIK and you see the patient maybe 5-10 years later, you would have seen the refraction does change a little bit. But in SMILE, the refraction does not change that much. It is very stable because of the biomechanical integrity that we preserve. So these are my results with SMILE of about 1,500 eyes over the course of the last 2.5 years. 99% of patients achieve 6.6 and 74% of patients achieve 6.5. There's no loss of 2 or more lines of best corrected vision. The accuracy is very good. 98.5% of patients are within half a diopter of spherical equivalent. 99.6 patients are within 1 diopter. Stability of refraction, we had it right up to 3 months. And then in astigmatism, 97% are within half a diopter of cylinder and 99% are within 1 diopter of cylinder. And the cylinder angle of error was very tightly controlled, which means we were able to very accurately treat cylinder even up to -5. These are the higher order aberrations that we checked using a night rays aberrometer. As you can see, in the post-op period, the higher order aberrations actually come down after we do the SMILE because of the shape of the lenticule. It is very even. It brings down spherical aberration. So we've seen this both in spherical aberration, but vertical and horizontal coma was slightly increased, but these are not very statistically significant. The only disadvantage is that there is no hyperopia treatment yet, but this is going to change in 2 months. There's a lack of customization where you can't treat HO waste directly, and enhancements can be a little bit tricky. You can do a post-PRK enhancement or you can do another LASIK enhancement on top of SMILE. So my 10 commandments are: don't underestimate PRK. It's still a reliable choice for low myopes and thin corneas. But you should question trans PRK because if the epithelium is not uniform, you can you blindly just go ahead and do a trans PRK. You can have refractive misses. So it's better to just do a PRK in itself. You can honor LASIK with decades of data, rapid recovery, and solid results. It's still a very good procedure. But beware of the flap because it does weaken the biomechanics and it can also cause more dry eye. Smile has better structural integrity because of no flap-related complications, and you have better stability of refraction. And because of the smile's nature of the profile of the lenticule, there's lesser HOAs and a better quality of vision even at night time. Nowadays, HOAs are also very tightly controlled because of the assistant guides that come with Smile. You have good centration guides and you can also correct high cylinder because of cyclotorsion adjustment capabilities that have come in the new machine. And do not fear the high myope. Even in Smile, where we've done cases up to -9, -10 diopters and we've gotten very good results. So thank you for your attention.
Yeah, meanwhile, Dr. Siddharth and Dr. Geeta, you saw how he bashed up TransPRK. LASIK established norms and provided the most modern data for Smile and around 10-year-old data for TransPRK. So, do you have any comments to make?
Very nice presentation, Aditya. I think Smile is the way to move on, but still, as you said, TransPRK has its own base of patients where you have moderate myopia and thin cornea. I think it's the safest procedure, and along with strengthening. Sometimes when you feel that it's a bit weak, you can go ahead with strengthening with C3 or also with TransPRK. And definitely each one has its role, Swapna. I don't think anything replaces anything, but of course Smile is now getting refined, but TransPRK definitely has its own role.
Yeah, I think I'll echo those sentiments. The first of the 10 commandments that you mentioned was highlighting the role of PRK, which I think still stands the test of time. So every procedure does definitely have its role, and I think it's up to us to be responsible enough to choose and advise the right one for the patient.
No, PRK I still do, ma'am. So I have no issue with PRK. TransPRK.
I understand and I agree with you regarding the epithelial variation, which can lead to variations in the outcomes as far as TransPRK is concerned. I think that's a very valid point which needs to be evaluated.
Yes, I think many people are not aware of the epithelial thickness because we have anterion, so we do. There's so much of variation in epithelium. That is there.
Epithelial mapping becomes a very important preoperative tool that needs to be performed in these patients to understand and explain and choose the right procedure.
So I think that should be added as one of the preoperative checks to be included in a routine workup. So I'd like to invite Dr. Quresh Muscati, our orator for the day, who has joined us, and he's a very experienced refractive surgeon. So, sir, your opinion on this?
I like the way you jump from TransPRK to Smile as if LASIK doesn't exist. So, as Geeta says, every procedure has its own place. I do all three of them, and according to me, there's nothing wrong in any of these. I've had people, critics of LASIK, saying for higher numbers, the amount of aberration you induce. Imagine if somebody who's got -8 or my limit is up to 10, I do LASIK. So even if you do that, the guy who's got -10 glasses, he's not bothered about the higher order aberrations. We are bothered because we have machines like iTrace. But the patient is not bothered. He's so thrilled. Even if he comes from -10 to -half or so, he's absolutely thrilled with his vision. So I think at the end of the day, you have to look at the patient first and see what will benefit the patient. Is he a sophisticated pilot or something like that, in which case you would do a different procedure. Is he a truck driver, you would do a different procedure, and so on. So I think fine-tuning to the needs of a patient rather than what our machines tell us would go a long way in deciding what is to be done when. Thank you.
Thank you, sir. Now, our next topic, Presbyond.
Okay. Yeah, so my next talk today is about Presbyond, an optimum solution for presbyopia. So I think I was a little misunderstood here. It's not that I hate LASIK because I still do Presbyond, which is a form of LASIK. Okay. So in essence, So we have to understand what Presbyond is here. So it's an excimer-based corneal refractive surgery for the patients above the age of 40 who have presbyopia. You can also treat their refractive error for myopia or hyperopia as well. So we should first understand how exactly Presbyond works. So immediately when you look at this, we see that in Presbyond, the dominant eye is targeted for plano to see very well for distance, and the non-dominant eye is targeted for minus 1.5 to see well for near. So the first thing that jumps to mind is that, okay, so this is basically monovision. But that's where it's not monovision. It's a little different from monovision. It's better described as a blended vision. So let us see first what challenges we have with monovision. So you do your monovision and you target minus 1.5 for the non-dominant eye, but you have a blur zone at the intermediate distance. So your laptops, computers, etc. are not very clear. The near eye will not have great distance vision. So this leads to anisometropia, which is difficult to tolerate. You'll also have a loss of summation and a loss of stereoacuity. So why do we stick to 1.5 as a target of the non-dominant eye? So if you look at the literature, it suggests that a defocus value within minus 1.5 will deliver the best balance of summation. That is, you won't have loss of stereoacuity, and at the same time you get good near vision as well. The same thing with the stereoacuity and if you're in binocular fusion. If you have the anisometropia within minus 1.5 diopters, you still retain good stereoacuity. So why exactly is Presbyond better than monovision? Yes, it uses the concept of monovision, but improves on all the disadvantages by having the spherical aberration at a target zone. So when you extend the depth of field by using spherical aberration, what happens is the near eyes also get reasonably good distance vision, and the distance eyes will also get reasonably good near vision. So what happens here is you have a natural binocular fusion of both the near dominant and the distant dominant eyes, which gives rise to a blend of vision. So how exactly does this happen? So what we have to understand is, by nature, spherical aberration is an anomaly that we are used to living with. The lenses that you use when you look through your car glass, look at a mirror, all of these have some amount of spherical aberration that you're used to dealing with every day in your natural life. And of course, our normal crystalline lens also has some spherical aberration by nature. Especially when you accommodate, the lens gets more spherical. You are getting more spherical aberration, and you can also see better for near. So it's not a very abnormal aberration for the eye. It's a naturally occurring aberration, which is why it's little easier to tolerate. So here we can see the difference between an image which has spherical aberration in the bottom and an image without spherical aberration in the top. As you can see, when you don't have spherical aberration, you only have one sharp focus. But when you do have spherical aberration, there is a circle of least confusion which is there, which is like a conoid of Sturm with astigmatism, where the image even before and after that point focus is still in focus. So you have an extended depth of field with this spherical aberration. But what we have to understand is how much spherical aberration is actually good. There is a therapeutic zone. When you target a spherical aberration between 0.3 to 0.6, you will have the advantage of extending the depth of field, while at the same time not degrading the quality of image too much. So within this depth of field, when you target, you will have the advantage of increased depth of focus while retaining good quality of vision. So this is what ends up happening in Presbyond. The dominant eye has a defocus of 1.5 diopters, which extends from distance to intermediate. The non-dominant eye also has another 1.5 diopters of extended depth of field, which goes from the near to intermediate. So both these eyes are able to blend really well for distance, intermediate and near, and they do not have anisometropia. Now the challenge with Presbyond is actually not with the procedure per se, but it's to do with the refraction protocol. The only caveat here is you have to be very, very precise with the refraction. With Presbyond, you cannot afford to be more than 0.25 diopters off target. So if you have more than 0.25 diopters off target, the patient will lose the blend and they will not be very happy. So you have to do this very carefully. And you look at the dilated exam, look for lens changes. If the patient has cataract, you have to disqualify them. You have to record the amount of spherical aberration in a dilated pupil. You have to look at the pre-op spherical aberration, input it into the laser planning, and the Presbyond algorithm will measure how much spherical aberration to induce for that patient. Accommodative age has to be measured, and all of this data is inputted into the laser. As a procedure, it's nothing different from LASIK at all. It's essentially femto-LASIK. So this is the procedure being performed. So this is the flap creation being done with the Visumax. You finish the flap creation and you move the patient onwards to the MEL 90 laser, and then you go ahead and do the laser ablation. That's about all. So these are my results. These are actually a little older. I've done close to about 80 patients now. So most of my patients always get 6.5 for distance, N5 for intermediate, and N5 for near as well. There is some chances that you might have to perform an enhancement because, as I said earlier, if you miss even half a diopter of, let's say, myopia or hyperopia, these patients will be unhappy. So you might have to enhance them a little more than you would have in your routine LASIK patients. So my first Presbyond patient I have to describe to you was actually an ophthalmologist. So she was a glaucoma surgeon from the UK. She came to us for Smile for her daughter. The daughter got it done, and she asked if she has some option for her. That's when we first got the Presbyond machine with us. We offered it to her, and after performing my first Presbyond case on her, then I realized how well this actually works. So I have to describe this to you. This is a pre-op refraction. She was right eye dominant with a minus 5.5 correcting to 6.5. Left eye was minus 7.25 correcting to 6.5. Her unaided near was N18. She needed a plus 2.25 to read for N6. And this was the simulation test. So the right eye, she was dominant, so we targeted for plano. Non-dominant left eye, you have to simulate the Presbyond test by putting a plus 1.5 lens to simulate a minus 1.5 target in the post-op. She was able to read N5 with the near eye with the plus 1.5, but her distance is only 618 in the near dominant eye. But post Presbyond, here is the result. She is 6.5 for distance, N5 for intermediate, N5 for near as well. Now, the dominant eye, which is only supposed to have a near vision of N18, improved to N10. Similarly, the non-dominant eye, which had a refraction of minus 1.5, had a distance vision of 6.9 parts. So what this means is that spherical aberration increased the depth of field in both the dominant and non-dominant eye. So it improved vision in both eyes, so they're able to fuse very well, and they have a good binocular fusion. We've also looked at it in the eye trace, where we've seen the depth of focus in both the dominant and non-dominant eyes, and we've tabulated all of this. We've seen in the non-dominant eyes get better distance vision than what is expected, and the dominant eyes get better near vision than what was expected after doing Presbyond. And in the eye trace also, we're able to see the same thing. The depth of focus increased in both the dominant and the non-dominant eyes, both in the hyperopic and in the myopic groups as well. So the only drawbacks is that there is an adaptation time. So after you do the procedure, there is a 1 to 3 month time in which patients might experience some blurring and some irritation now and then, but they have to adapt and wait until 3 months. The steep learning curve is for patient evaluation. The refraction has to be very precise. One must be ready for enhancements in case the patient is not happy. And obviously, it will not work if the patient is amblyopic in one eye. So, of course, the patients can achieve good visual outcomes with distance in intermediate and near. Cross blur is much lesser due to spherical aberration being there at the target range. Even though we have some spherical aberration being induced in Presbyond, it does not significantly reduce contrast. So I'll have to end my presentation here with the last 2 slides. So Presbyond is something that's not very easily understood by most of us. Even I had to go to London Vision Clinic and attend the course by Professor Dan Reinstein to actually understand it. So there was an interview in which he gave his 3 wishes. So one of the wishes was, I hope every day, next morning when I wake up, everyone in the general population understands about the safety and efficacy of laser vision correction. Second wish is that I hope on next Monday when I wake up, all ophthalmologists instantaneously knew the facts about the safety, efficacy, and stability of Presbyond in comparison to doing a clear lens exchange. So I had this same tussle with my father when I went back to my practice, and I said, stop doing lens exchange, let's do Presbyond only. He refused at first, but then after about 8 months of doing Presbyond, he himself got it done, and it's been about 3 months now, and he's very happy now at the age of 67 without any glasses. Right. So these are my commandments. So when you're doing Presbyond, you have to be very careful with the evaluation, set clear expectations, understand that all spherical aberration is not bad. Some amount of spherical aberration is good to extend the depth of field. Evaluate the pupil size under mesopic conditions. You have to see this to ensure that the blend zone is okay. Use the aberrometer or eye trace or any equivalent device to see the difference in the depth of field. Tailor the monovision test to the individual. Not everybody will accept the minus 1.5 diopter test. They might accept only 1.25 or minus 1. If that is what they accept, you have to give that to them. There is a difference between myopes and hyperopes. The post-op period, because myopes have more positive spherical aberration, they'll be happy with the distance vision, but the near vision will be a little less clear for them, but they'll have to adjust to it within 3 months. Similarly, for hyperopes, because of negative spherical aberration, near is better than distance for the first 3 months. You have to tell them that this will take time to adjust. The most important thing is it preserves the patient's natural accommodation. So, as opposed to doing a clear lens exchange, when you do Presbyond, patient's accommodation is still there. So, they have a much better range of vision. And prioritize ocular surface health before and after surgery, because any amount of dry eye or inflammation can really mess with the refraction and the spherical aberration, which can induce your outcomes after doing Presbyond. So, thank you for your attention.
Thank you, sir. That was an elaborative discussion. So always we have to counsel the patient about the enhancement chances.
Yeah. Yes.
Any discussion from the audience? Any questions?
Yeah, so the thing is, when you're doing it for a patient in the early 40s, they might only accept +1 or +1.25 in the non-dominant eye. So for those patients, if you do the Presbyond, it will probably last maybe about 5 years, and 5 years later, they may need a touch-up in the non-dominant eye alone. But if you are doing it for someone who's in the late 40s or early 50s, you give them the full treatment. So when you give the full treatment, it's going to last them until they have cataract.